So I'll be talking about, so we're used to taking blood pressures at home. ये प्रोजेक्ट हो रही है? Okay, nothing relevant to disclose. So issues in the diagnosis. So imagine a 35, 36 years old person who is very fit, takes care of himself, goes to a friend's house, has headache, checks blood pressure by the apparatus that he uses, the friend uses for his mother, and his blood pressure comes out to be in the hypertensive range. He's now worried. He comes to your clinic. You check blood pressure in your clinic, and his blood pressure actually comes out to be high. So what do you tell him? Does he have hypertension? Do you know, he needs to have this fear allayed. He does not have family history of hypertension, and he does not have risk factors. He's very active, and he wants to know his age is about 36. So issues in the diagnosis of hypertension, the accurate measurement of BP is essential, that we all know. The shift from the old gold standard, that is mercury devices, has happened, but it's yet not complete because a lot of devices are still in vogue and actually are being used for studies as well. Increased use of oscillometric devices, that's good. Discrepancies between clinic and out of clinic blood pressures exist. We are all aware of that. Concerns about measurement error with manual BP measurement techniques have resulted in uncertainty for clinicians as well as researchers. So we are well into centuries of work has been done on understanding of hemodynamics and blood pressure, but yet we're not sure whether what we are measuring is actually the true mean. So this is what we are used to in clinic physician taken blood pressure. So the question is, we all know studies, data have shown that there can be as much as 30% difference from the true mean. That means you will be having erroneously raised blood pressures in the clinics. So the white coat effect and white coat hypertension is something that does not allow us to freely operate in this setting. And this is the setting we are most used to. So if you, for accurate reading, we now understand that you should have the same setting, same attending person, multiple readings, and across multiple appointments or multiple visits. So when you actually try to find the true mean, it's a tedious task. So the 3-in-3 rule is that you take 3 readings across 3 months. That may give you some sense of what the true blood pressure reading is. Now, our concern is that we have got busy clinics, and despite the fact that nearly for significant years we know that what we take in our blood pressures is not the true mean, yet we have not changed our clinic infrastructure. So the accuracy of readings in the clinic is dubious, and the diagnosis of hypertension therefore requires that we either improve the measurement inside, or we move out of the clinic, or more so out of the hospital. Multiple readings, I have given you the 3 readings. This is our guidelines, and you can see this is the diagnostic algorithm, and it requires a screening visit number 1, visit number 2, and at the end, if you look lower down, there is home blood pressure monitoring, there is ambulatory blood pressure monitoring, and there is averaging of multiple readings across clinic visits. So it's not a diagnosis of hypertension, and trying to find that true mean, which I call the truth, is not that easy. So over the past 40 years, devices have been developed and validated to estimate blood pressures. We have very good ambulatory blood pressure monitoring systems. We have home blood pressure monitoring devices which take out the alert response or the physician or the nurse's response out of the equation. We have automated devices that can take multiple readings across set intervals. So you don't, and when they are fully automated, they do not require an attendant. So they will take 1 reading, then after 1 minute, they'll take another reading, and after 1 minute, so they can take multiple readings and log the readings. And that's very, very important. In semi-automatic devices, the person will have to take blood pressures himself or herself, and even that can cause some degree of change in the blood pressure, because blood pressure is a very, very sensitive moving target. So if we look over here, I don't have a pointer, but if you look over here, so basing around the clinic blood pressure, you have the pre-clinic blood pressures which were taken by the nurses, and they generally used mercury, and now they're using oscillometric automated devices. Up over there is unattended blood pressure, which the SPRINT trial used, where there was no attendant and you had an oscillometric device. Then there's a concept of post-clinic, and I'll walk you through it. That is the studies that we did, that we believe that after you leave the clinic, your blood pressures will be lowest as long as you are in the perimeter of the clinic. And then of course you have home blood pressure monitoring and ambulatory blood pressure monitoring. And why are those important? Because the cardiovascular endpoints are better associated with the ambulatory and home blood pressure monitoring than with clinic blood pressure. Now, there have been trials that have shown that community pharmacy and grocery store blood pressure measurements are also giving us reliable information, because they're multiple, they're out of the hospital. But can we rely on this? We don't know. And then of course you can take blood pressures at different places where you have a mass input of people coming in, and you can take lots of these readings. So this is one of the studies where we are taught to take multiple readings and discard the first reading. And they did this study, and they showed that if you discarded the first BP reading, it did not change in that clinical setting, did not change much, and that its association was not great, but it remained the same with the ambulatory blood pressure monitoring, despite the fact that you were discarding the first reading, which we believed कि बड़ी बहुत ऊंची आएगी, so therefore it will skew our average. And if you look at the ambulatory and the mercury, there isn't much difference. But what is important to understand is, it is the man who's taking the blood pressure. If the man is the same or the woman is the same, the blood pressure will be more fluid, more fluent actually. And it's the device that you're using. Even when we're using devices, we should thumbprint, like phones for example, there is a thumbprint for each oscillometric device, also automated devices, so we should know that, and it should be the same device measuring blood pressure. That needs to be understood. Now, this is another the question of variability, and they checked it in the elderly. Elderly are a good prototype because they give wide ranges, and therefore you can study a phenomena easily. And they showed that if you were to take 3 readings, in the third reading there was significant drop in the blood pressure in the same setting, up to 11 millimeters of mercury for the third reading, and if you're taking 2 readings only, it was 6. So these are very, very important undertakings. So this is the study I talked to you about. This was the first paper that we wrote. It was after 15 minutes after the clinic visit was over. We took blood pressure, and we showed that the lowest systolic blood pressure in the clinic, this is the first one is pre-clinic by the nurse, then by the physician, and then by the person taking blood pressure in the clinic area after the visit was finished. And we clearly showed that this was significantly different, at least 10 millimeters of mercury from in-clinic to post-clinic. So post-clinic was the lowest. It was even lower than the pre-clinic nurse's blood pressure. So we did, people laughed about it. We then got the ambulatory blood pressure monitoring study done with it, and we showed that the coefficient of correlation, that the Pearson's correlation was moderate. And if you look at the graph down there, you can clearly see that it's 0.6, so there was more association, and the post-clinic blood pressure was the lowest. So this is something that we can use, and we've used it in our guidelines. If you want to use it, if you have the time, you can take the patient back, or you go with home blood pressure monitoring. This is a study where they compared blood pressure in the community pharmacies and compared it to ambulatory, home, and general practitioner office readings. And they showed that this reading was higher than the ABP, which is acceptable. It did not give a real reading with the GP clinic readings, because the GP clinic readings were very heterogeneous. And with the HBP readings, again, were non-significantly. When you're taking home blood pressure monitoring, how many readings will give you the true mean? So in this study, they showed that if you were to take 3 Using the average of morning and evening readings, that is 2 in the morning, 2 in the evening, 3 days of home blood pressure monitoring, this was enough. So guidelines recommend 4 and maximum up to 7 days would give you real good readings. But if you were constrained for time, then it would probably be good to go to 3. So it will give you 6 readings and over time, and that 6th reading would give you bring you close to the mean. So that would help you in the diagnosis of hypertension. So I will conclude, and my conclusion would be that we need accurate BP measurement to diagnose hypertension so that we can treat it and bring the patient under control. And this control in our countries is still not up to the mark. It's very dismal. Clinic setups for BP measurements are not standard and need to change. It means that it's going to be a huge change. If we cannot do that, then we should find alternate ways to assess blood pressure, and out of hospital blood pressure, home blood pressure being the best is what is now recommended. So out of clinic, out of hospital readings are vital as they give us more readings over a longer period of time, and these are unattended. So if these are unattended, these are the best readings. Physicians should encourage out of hospital assessment, so we need to change our frame of mind as well and have more acceptability for home blood pressure monitoring. And if you want to make a dent into the dismal national figures for the control, take-home message would be that take in-clinic blood pressure if you have to, but rely more on the out-of-hospital blood pressure because that is vital. Thank you.